Dearly beloved, we are gathered here today to get through a little thing called lipid and diabetic pharmacology. Welcome back to another Robjob Rapid review. I am so sorry for the hiatus from pharmacology. I was stressed. But here we are. As I said, we're getting into lipid and diabetic pharmacology. I did what I could. We did what we can. You know how we do it here. We formulate some sort of mnemonic and we give you tools that definitely work for me because I'm crushing these exams, but I hope that they work for you. Let's get into some anti-lipid drugs. So this is covering hypercholesterolemia and hypertriglyceridemia, and it is mainly characterized by when patients present to your hospital with an LDL greater than 190 milligrams per deciliter. So if they're greater than 190, when you take their lipid panel, you're hitting them with these. And what's the mainstay drug, everybody? The mainstay drug is statin. We've got simvastatin, corvastatin, all of the statins. The mechanism of action is HMG-CoA reductase inhibitor. And the mnemonic for that, if you already haven't heard the word statin, and if you haven't heard the word statin, where are you? Hamburgers. There's a lot of hamburgers. There's a lot of statins. HMG, hamburger, CoA reductase inhibitor. This will do two things. This will decrease hepatic cholesterol, and it will also increase the LDL receptor. So there will also be decreased synthesis and also increased uptake, which will lead to lower LDL in the bloodstream. Things to note is that this is a pro-drug, so you need CYP to get this into the active form. So if there's something that inhibits CYP, you're going to have less drug. And if there's something that amplifies CYP, you're going to have more activity and it's going to be more potent. It does have a cardiovascular benefit. The next thing is our ATP citrate lyase inhibitors. This is bempedoic acid. This inhibits the enzyme ATP citrate lyase upstream of the previous drug. And we don't have a lot for this one. I talked to multiple physicians, not being used. It's a new drug, but just know that bempedoic acid is upstream of our simvastatin. The next drug is ezietemab. Ezietemab, the mnemonic is ezietemab. IB. It's in the intestinal brush border cells. So here we have the IB and IB. So just think intestinal brush border, and then it's inhibiting the transporter MPC1L1. That channel is shuttling cholesterol into the body. So that is ezietemab. Ezietemab is the MPC1L1 cholesterol uptake. Next thing is the PCSK9 inhibitor. That is evolucamab. Again, pretty weak mnemonic on that, but what I think of is like an evolution, and I think of a protein. That protein is PCSK9. That protein is going and it is inhibiting the LDL receptor. So if we inhibit the protein that's inhibiting the LDL receptor, we have more LDL receptor, we have less LDL in the serum. So evolucamab inhibits PCSK9. The next drug is cholestyramine. Cholestyramine. What do we think of when we think of chole? We think of the gallbladder. What do we think of when we think of the gallbladder? We think of hepatic recirculation in the mediastinal ileum. So we think of cholestyramine. We think of less bile salts getting uptaked. Less bile salts equals less cholesterol equals less LDL. Cholestyramine, think bile salt. And last but not least, but first but not last, we have gemfibrozil, hypertriglyceridemia. So all the drugs before are mainly used for cholesterolemia, but this one is specifically used for hypertriglyceridemia. That's when those triglycerides are somewhere between 500 and 1,000 milligrams per deciliter. In gemfibrozil, we're thinking hit a gem for par 3. You just went to the golf course, you drove the ball, it's going, you putt the ball, you got par, you hit a gem, PPAR alpha agonist. Gemfibrozil is the PPAR alpha agonist. So there we go, folks. Just remember with the anti-lipid drugs, we have the statins, HMG-CoA reductase. Don't forget about ezietemab and evolucamab. Those are the two drugs with the NPC1L1 and then the PCSK9. And those are the main drugs that you're going to hear about when it comes to anti-lipids. But now on to the diabetes drugs. Ladies and gentlemen, this is systemic independent epidemic. It's everywhere. It's going to be in the clinic. You will see it. You might have it. Get your blood drawn. But anyways, we are going to go through this. What is the main drug for diabetes? Well, let's talk about first when a patient has diabetes. Well, first, they have diabetes if they have a random glucose above 200 milligrams per deciliter and they're symptomatic. The second, if their A1C is above 6.5%, if they have a fasting glucose greater than 126 milligrams per deciliter, or they do an oral glucose tolerance test and they are greater than 200 milligrams per deciliter. That's the criteria. Ideally, we have 2 of the 4. If you only have 1, use your clinical judgment. First drug that you are always doing is med lifestyle. Lifestyle, everybody. Exercise and diet, then metformin. Don't have a mnemonic. You should know metformin. Again, you might be using metformin. What does it do? The mechanism of action, it decreases hepatic gluconeogenesis. That's what metformin does. That is the mainstay. Interestingly enough, we don't really know the specific mechanism of action, but when it works, don't question it. Next drug, glipizide. Glamping K. Want to go glamping? K. Want to go glamping? K. Glipizide is the glamping drug. We think of it blocking K. What happens when you block potassium in the beta cells? Well, then you have calcium coming in. What happens when calcium comes in? Insulin goes out. More insulin equals less glucose. But also, this leads us to our important side effect. This is the only drug besides the insulin drugs that could lead to hypoglycemia. What are you associating glipizide, glamping K with? Hypoglycemia. The next thing is canalgiflozin. When I think about this, I think of a canal and I think of glucose flowing through the canal. How's it flowing through the canal? We are blocking the SGLT2 channel. In the proximal channel of the kidney, don't quote me on that. Anyways, we block it. Glucose is flooding out of the system. What is important about this drug? This is one of the drugs that can lead to weight loss. So canalgiflozin, flowing glucose out of the urethra, canalgiflozin. Side effects include euglycemic diabetic ketoacidosis and UTIs. The next drug is pioglitazone. Pioglitazone is the PPAR gamma agonist, kind of similar to our last mnemonic. It's a stretch, but pioglitazone, glitta when you hit par. You know, we're celebrating. You don't hit par that often in golf. Pioglitazone, glitta when you hit par. PPAR gamma agonist, this will reduce glucose as well, but is not used as often as the aforementioned drugs. The next 2 drugs deal with GLP-1. GLP-1 is a molecule that increases satiety. It also upregulates insulin and downregulates glucagon, and that's GLP-1. We have liraglutide and we have sitagliptin. The main one that we should focus on is liraglutide. This is actually going to agonize and increase GLP-1. Increased GLP-1 means more satiety, means more weight loss, means less blood sugar. That's the main one that we're looking for. And then the only mnemonic that I can think of with that one is Lyra, quit. You need to quit and you need to lose some weight, Lyra. I love you, Lyra, but just lose a little bit of weight. And then the second drug, sitagliptin, sitting down at the PlayStation 4. Just know that that inhibits the DDP4 enzyme, which then decreases GLP-1 receptor. So that's on a receptor level. Liraglutide is on the molecular level. Last but not least, we have acarbose. What do you think of when you hear agonize? When you think of antithesis? When you think of acarbose, you think of without. So acarbose, without carb. You do not have carbohydrate uptake in the small intestine. Therefore, less carbs. Therefore, less diabetes. So all of those drugs that I just mentioned are used for type 2 diabetes. This is the main thing that's associated with insulin resistance. It is mostly a lifestyle, but can be a genetic disease, but it happens more later on in life. These next 3 drugs are dealing with type 1 diabetes. This is an autoimmune attack on the alpha cell, on the beta cell of the pancreas. So what are the 3 insulin drugs that we need to know? Insulin glargine is the first. What do you think of insulin glargine? Well, I think of glaring for a really long, extended period of time. Insulin glargine is the long-acting insulin. So contrasted with that, we have the short-acting insulin. The short-acting insulin is the insulin lispro. You know, the lispro. They want the quick lease, the quick money. Insulin lispro is the fast-acting insulin, and then the intermediate is the NPH insulin. All of these can lead to hypoglycemia because insulin is just wide open, shoving glucose into the cell. If you're shoving glucose into the cell, you could have and be at risk for less glucose in the serum. So that's about it. One thing that I do want to discuss is money, because money is important. Money is just driving so many decisions. So let's talk a little bit about money. So in terms of insulin, the short acting is always going to be the cheapest. The short acting, the insulin lispro is, about $11 at your local Walmart, but the insulin glargine, the long acting, that's going to create that basal level. That one is going to be stiff. That one's about $350 for a 3 milliliter vial at your local Walmart. So just be aware. But the ideal treatment for type 1 diabetes is you create that basal level of insulin, and then you also administer insulin after meals, postprandial. For type 2 diabetes, thank you to Walmart and Mr. Wally. We have $4 drugs. It's going to be metformin, glipizide, and pioglitazone. I think is just a skosh over $4, but you just can't beat that. It's a $30 supply for your glucose to be at a normal level, for your eyesight and your neuropathy to be beautiful. That's all I've got. I know we're a little rusty, but that's a Robjob Rapid review. Lipid pharmacology, diabetes pharmacology. Cheers. Namaste.